This is Dr. Michelle Cotty, and today we're going to be talking about antipsychotics. The objectives for this lecture are that by the end of it, you'll be able to identify the medications used to treat psychotic disorders. The goal is to memorize the drugs in each category and be able to summarize the adverse effects of each medication. Today we're going to discuss antipsychotics, and antipsychotics are most often used for patients who have schizophrenia. So schizophrenia often involves the acute exacerbation of symptoms, and then there are periods of remission. The symptoms might remain present, but be much less severe on the medication. Antipsychotics can treat the positive symptoms of schizophrenia, and these symptoms are related to behavior, thought, and speech, and they could include agitation, delusions, hallucinations, or unusual speech patterns. Negative symptoms are when the individual is missing things. So they might withdraw socially, lack emotion, lack energy, have flattened facial expressions, lower motivation, and a decrease in pleasurable things. The goals of these medications is to suppress acute episodes, prevent acute recurrence, and maintain the highest possible level of functioning. The medications are broken into two categories. First generation, or conventional antipsychotics, are primarily used to control positive symptoms of psychotic disorders, and they're reserved for individuals who can use them successfully, tolerate the side effects, or who are particularly violent or aggressive. Second generation, or atypical antipsychotics, are the preferred medication because they have less side effects. They relieve both positive and negative symptoms, decrease findings in depression and anxiety and suicidal behaviors. They can improve memory, have fewer EPS, including tardive dyskinesia, because there is less dopamine blockade, and they have fewer anticholinergic effects. The exception for that's clozapine, but most of the atypical antipsychotics have little or no blockade of cholinergic receptors. So because there's less side effects, we see less relapse on these medications. And here is a list of the first generation, or conventional antipsychotics, and second generation, or atypical. Unfortunately, there is no easy way to memorize these medications, so practice, practice, practice. First generation, or conventional antipsychotics, have an expected pharmacological action of blocking the dopamine, or D2, acetylcholine, histamine, and norepinephrine receptors in the brain. It's believed that the inhibition of psychotic symptoms is a result of this D2 blockade. Therapeutic uses include treatment of acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar disorder, especially the manic phase, Tourette's disorder, and it can help prevent nausea and vomiting through blocking of dopamine in the chemoreceptor trigger zone of the medulla. The first generation, or conventional antipsychotics, have complications and side effects that we need to watch out for. Agranulocytosis is a serious side effect. It's when there's an extremely low number of granulocytes, which is a type of white blood cell in the blood. So we want to make sure that we have a baseline white blood cell count and look for indications of infection. So if a patient has a fever, complains of a sore throat, make sure you're looking at their white blood cell count. Anticholinergic side effects, so that's the can't see, can't pee, can't poop, dry mouth, and tachycardia. Acute dystonia is a severe spasm of the tongue, neck, face, and back. It can start 5 hours to 5 days after starting the medication. You can imagine how scary that would be as a patient. And we treat acute dystonia with Benadryl or Cogentin, and this is a serious medical complication. So first generation conventional antipsychotics can have side effects called extrapyramidal symptoms, EPS. So acute dystonia that you saw on the previous page, which is that tongue spasm or neck, face, or back spasm, that's one of the symptoms of EPS. Parkinsonism, akathisia, and tardive dyskinesia also are. So Parkinsonism is when the patient experiences bradykinesia, they have a shuffling gait, they might be rigid, drooling, have tremors. And we want to observe for these signs and symptoms during the first month after we start therapy, and treat this with benztropine or Benadryl or something called Symmetril. Akathisia is when a patient looks really restless. They're pacing, they're agitated, they can't sit still. You can use benzodiazepines, anticholinergic medications, or beta blockers to treat those patients. And for tardive dyskinesia, which is this late EPS, so it's when the EPS symptoms have gone on for a long time, we're going to see involuntary movements of the tongue and face, lip smacking, tongue vacillations, involuntary movements of the arms, trunk, and legs. So we want to try to prevent this by continuously evaluating the patient. You can do an AIMS screening tool, which we will talk about. But the idea is to prevent this from happening. So first generational or conventional complications continue. So neuroendocrine. Patients can experience gynecomastia, galactorrhea, or menstrual irregularities. So you can imagine this is a side effect profile that is really challenging when a patient needs a medication and are having these sort of side effects. NMS, or neuroleptic malignant syndrome. The patient might have a sudden high fever, blood pressure fluctuations, heart dysrhythmias, muscle rigidity, changes in LOC, and a coma. So stop the medication. This is an emergency. Other side effects include orthostatic hypotension, sedation, seizures, and severe dysrhythmias. These medications are going to be contraindicated if the client is in a coma, has severe depression, Parkinson's disease, prolactin-dependent breast cancer, severe hypotension, in adults with dementia. And you should be really careful if the individuals have glaucoma, a paralytic ileus, enlarged prostate, heart disorders, liver or kidney diseases, or a history of seizures. So there are some medication interactions that we would like to discuss now. Anticholinergic agents, if we use those with the medications, it increases the effects of the medications. So you want to tell your patients not to use sleep aids that are over the counter. We don't want to take these medications with alcohol, opioids, or antihistamines. And levodopa counteracts the effects of antipsychotic agents because it actually activates the dopamine receptors. Remember that the abnormal involuntary movement scale, or AIMS, is used to screen for the presence of EPS. So these are just like some tidbits. We need to differentiate between EPS and just worsening of the psychotic disorder. We use anticholinergics, beta blockers, benzodiazepines to control early EPS. Sometimes we have to switch medications, so make sure you're communicating with the prescriber. It's important that patients take this medication as prescribed. The medications don't cause addiction. Clients can see noticeable effects of the medication within a few days, but 2 to 4 weeks is not unreasonable for the medication to take full effect. Many of these medications are available in an injection for individuals who have difficulty with medication compliance for whatever reason. So lower doses can be used in the injection, and then they have lower side effects. and have a lower risk of developing the tardive dyskinesia. When we administer the medications, often some of these medications are given twice daily, and then it's switched to daily dosing at bedtime. That helps decrease daytime drowsiness and it promotes sleep. Second generation or atypical antipsychotics have an expected pharmacological action of blocking serotonin and to a lesser degree the dopamine receptors. These medications also block receptors for norepinephrine, histamine, and acetylcholine. They're used for the negative and positive symptoms of schizophrenia spectrum disorders, for psychosis induced by levodopa therapy, and for relief of psychotic manifestations in other disorders like bipolar disorder. Complications for these medications can include an onset of diabetes mellitus or a loss of glucose control in clients who have diabetes. So we want to obtain the client's baseline fasting blood glucose and monitor the value periodically throughout this treatment. Make sure to let the client know they need to report things like increased thirst, urination, and appetite to the provider. These medications can cause weight gain, so we want them to have a healthy diet and engage in regular exercise. We want to monitor that weight gain. If they've increased more than 30 pounds, then we also need to monitor their cholesterol, triglycerides, and blood glucose, because these patients can be at increased risk for hypertension and other cardiovascular disease. If there are significant changes in orthostatic blood pressure, we want to monitor their blood pressure and heart rate and notify the provider. Again, these medications can have anticholinergic effects. So can't see, can't pee, can't poop, dry mouth, tachycardia. Encourage the patients to sip water throughout the day, chew sugarless gum, urinate prior to taking the medication. Some of these medications can cause agitation, dizziness, sedation, and sleep disruption. So make sure the patients know not to drive if they're feeling tired. And we want to use the AIMS screening tool to monitor for mild EPS, so we might see hand tremors. These medications are pregnancy risk category C. So individuals who are pregnant or breastfeeding should exercise caution and work with OB. The medication should not be given to individuals who have dementia. They could cause death related to cerebrovascular accident or infection. They should avoid alcohol with them. And we should be cautious in clients who have cardiovascular, cerebrovascular disease, seizures, diabetes mellitus. And make sure if they have diabetes that we monitor their fasting blood sugar and blood glucose. Second generation atypical antipsychotics have medication or food interactions that we will discuss now. So medications that are immunosuppressive in nature, like anti-cancer medications, can further suppress immune function when taken with drugs like clozapine. We also want to avoid, again, alcohol, opioids, antihistamines, and other CNS depression medications. Levodopa can activate dopamine receptors and it counteracts the effects of antipsychotic agents. We want to avoid medications that prolong QT intervals because this increases the risk of cardiac dysrhythmias. These include TCAs and other medications. Medications like barbiturates or dilatins stimulate hepatic drug metabolizing enzymes, and this decreases drug levels like Abilify, quetiapine, and ziprasidone. Diflucan inhibits hepatic drug metabolizing enzymes, increasing drug levels of Abilify, quetiapine, and ziprasidone. So for the last two, we just need to monitor the medication effectiveness.